Hello, everyone. Thank you for joining us in Dietitians Network of Canada's second webinar in the Diabetes Education Series. Dietitians Network of Canada is an organization for all dietetic professionals around the world. IEDNC was established to help meet the needs of internationally trained dietitians transitioning to Canada, those who are already in Canada, and those who are around the world pursuing a career in dietetics. We provide education, mentorship, support, network, and guidance throughout this entire process of joining the field of dietetics. Today's webinar is being hosted in collaboration with LMC Healthcare, which is Canada's largest specialist care provider in diabetes and endocrinology. So as you all may know, the prevalence of diabetes is increasing drastically around the world. And it is crucial that as healthcare professionals, we continue to enhance our knowledge in the vast realm of endocrinology and diabetes so that we can always continue to provide the best care possible to our clients and patients. I would now like to introduce Tara Abu-Klam. She has almost 4 years of experience working with LMC Healthcare, and she will be teaching us about the ins and outs of insulin today. Just a brief reminder, there will be a Q&A session at the end of the webinar. It'll be roughly 5 minutes, but please do continue to send your questions in the chat. I will read out the questions to Tara at the end, and she'll kindly answer them in the best way possible. Just in case, if any questions are missed out or we run short on time, just drop the questions in the email or in the chat, and we'll definitely get back to you following the webinar. Just another kind request to stay muted throughout the webinar so we can let our wonderful guest have the spotlight today. Go ahead, Tara.
Thank you so much for having me and for the lovely introduction, Noor. I'm happy to be here and be able to spend the morning with folks from all over the world, and hopefully you'll find the session informative and interactive. So I'm going to share my screen right now. All right. Okay, so today we will be talking about insulin, and we'll do a little bit of a background of what it is. I'll explain the different types that are available and their actions. We'll discuss the injection technique and insulin handling. I'll do a little demonstration for that. We'll talk about side effects and how to manage them. And when we would like to be checking the blood sugars, when should we be asking our patients to do that? And how do we adjust insulin if you have medical directives? And at the end, we'll go through some questions and answers. So what is insulin? Insulin is a hormone. As we know, our body produces it every time we eat foods that have carbohydrates in them, like grains, fruits, milk, sweets. All of these grains, we digest them and they turn into glucose or sugar after the digestion. That sugar needs to be transported and taken into different parts of our body to give us the energy, of course. And the pancreas produces this hormone, insulin, to help us transport these sugars to where they need to go so that we can get the energy that our body needs. Of course, this is another analogy that we often use with our patients too, is that insulin acts like a key. It opens up the doorway to our body cells and allows the sugars and the energy fuel to go in the organs and help us do everything that we do, all the awesome things that we do throughout our day. When people have diabetes, unfortunately, something in that cycle just does not work optimally, which is either the production of insulin from the pancreas is not sufficient, so there ends up being more sugar than insulin, and we're not going to be able to absorb them fast enough. Or there could be insulin resistance. So insulin resistance is when this thing over the doorway on the cell just does not open up very well. I'm going to get my laser pointer here. There you go. So Insulin resistance is when this doorway just does not open up, and the sugars will also start to accumulate in the blood. Something that's a misconception among patients is that only people with type 1 need to be taking insulin, and people with type 2 don't have to. Or if they do end up taking insulin, then they have type 1 diabetes. That is a misconception. It is not true. Anybody who has type 1 or type 2 can be managed with insulin, and people just need to think of it as another therapy, another option of therapy for diabetes. It is not a replacement of lifestyle modifications, diet, physical activity, or other pills or other oral pills that they take. It is simply another therapy, something else to help them get the sugars to where they need them to be. There we go. So what are the types of insulin? In general, there's a general categorization, which is either basal insulin or bolus insulin. Basal is also another name for it would be background or long acting. The bolus, another name for it will be mealtime or rapid insulin. But over here, I have broken them down into the different types. So some of them are older. We don't really use them as much. We don't see them as much in today's therapies, but some patients would still benefit from them. So I would say the majority of the time we see people on rapid acting insulin and the extended long acting insulin. Both of those together, they would help resemble a little bit more of what the pancreas does with the insulin production and how it can control the blood sugars whenever we eat or when we're fasting. So the rapid acting insulin, examples of that would be Humalog, Apidra, or Novorapid. And they typically start to work in 10 to 15 minutes, and then they have a peak right about 60 to 90 minutes. That's the peak that you see over here. And it will stay for the duration. The whole duration would be roughly about 4 to 5 hours. The idea is that this peak, when it happens, it will be at the same time where the peak of the digestion of the carbohydrate is, and that's where the sugars tend to be the highest. So ideally, it will match up together and bring down the levels from eating the meal that has carbohydrates. Fast-acting insulin, which is the slightly older version of it, or another term of it would be short-acting insulin. It starts to work in 30 to 60 minutes. So as you can see, now we're kind of stretching the time a little bit longer. The peak can last anywhere from 2 to 4 hours, and the whole duration of the insulin will stay for roughly about 5 to 8 hours. So it does make things a little bit more challenging, and in some cases, especially depending on people's lifestyle and what kind of meals they're eating, how often they eat. This can be an option for some patients, but it has to be really taken on a case-by-case basis. The intermediate acting insulin starts to work in 1 to 3 hours. It peaks at around 5 to 8, as you can see over here, and it can stay up to 18 hours. Now, this is what we used to consider it would be the old type of extended insulin or basal insulin. This is what we used to have. But as, of course, technology, medical advances happen, we now have extended long-acting insulin, which is it's like a flat line, like that goes throughout the day, the same level, doesn't have a peak, and it's supposed to help with the sugars when you're fasting, when there's no food. Most of the time, it works during like the nighttime hours when people are sleeping. The other three, of course, as you can see, they have a peak, so they could be a little bit more tricky when it comes to dealing with the side effects, which we will be discussing a little bit later on. There's, of course, a premixed insulin. So premixed insulin would have a combination of 2 types. It's usually the intermediate acting, so this type of insulin, And they either have the fast-acting insulin with it or the rapid-acting insulin with it. And I'll show you a demonstration of how they look like. In terms of the duration and the peaks, they will be kind of just the combination of both of these insulins together. So the graph will look the same. There's another, this is a more recent one, maybe in the last 2 or 3 years, I would say. We now have insulin and GLP combo. The insulin that they use for this is always the flat one. And there's two main brands out there. There's Zoltafy and Soliqua. And essentially what this is an insulin, a long-acting insulin in combination with a GLP-1 receptor agonist. So the Zoltafy, they use Victoza. And the Soliqua, they use Adlixine. And I mentioned this because some people also confuse GLP-1 receptor agonist as insulin, and it is not insulin. And I put it over here as well. So you might have heard of meds like Ozempic, Trulicity, Victoza. These are all injectable diabetes medications, but they're a different type of hormone. It's a GLP-1 receptor agonist, and it helps control the appetite, controls the blood sugar management, increases insulin production, but it is not insulin in itself. So we do not handle it the same way that we would handle insulin in terms of titration, timing, and all of that. Although they are very helpful for people's blood sugar and control. Over here, I have some of the demonstrations to give you a little bit more visual of how these insulins look like. So as I mentioned, the rapid-acting insulin, the green one over here, and the dark blue, the long-acting, extended long-acting, these are the ones that we typically would see in patients nowadays. The rapid will be taken with every meal, or maybe with the biggest meal that the patient has. I have some patients who would maybe only take it with breakfast or with dinner, and then they would take another basal insulin like Lantus or Tresiba. The short-acting insulin, as you can see over here, is the one that has a little bit of a longer peak, so between 2 to 4 hours. And as you can see here, there is a chance for low sugars to happen at that point if the duration between the meals, or the gap between the meals, is longer than 5 hours. You'll see that, the food is all digested, the sugars are all down, but then the insulin is still acting at its peak, which could lead to low blood sugars. So we would need to be careful with that. Another thing that you would want to maybe consider with this is making sure that you let the patient know that they need to take it about 30 minutes before they start eating. So because it takes 30 to 60 minutes to start to work, you want to give them enough time to try and match that peak as much as possible with the food digestion. Whereas the rapid-acting insulin, you can direct your patients to take it 10 to 15 minutes before eating. That usually is sufficient. The long or extended long-acting insulin, like this one, Lantus, Tresiba, Levemir, and whatnot, they usually are taken at the same time every day, consistently. So we try not to give too much of a leeway, I guess, with the timing. So if they take it at around 8 a.m. or 8 p.m., they just want to stay within that hour every day. In some situations like Tresiba, if they forget it, then they can still take it after a few hours, as long as there's 8 hours difference between the two injections. So that would be an exception there. The intermediate or acting insulin, NPH, examples of that would be the Humulin N. It has a peak right around 5 hours. It's the old style of basal insulin. As you can see here, usually you would take it at bedtime. It has a little bit of a peak after the 5 to 8 hours, so it can cover your evening or overnight sugars, and also the morning levels, like when you wake up and have the meal. So again, there might be some risk of lows at that point if the meal is delayed or if there's long gaps between the food timing. And slide is not always there you go. And in terms of the premixed insulin, so this is what we were talking about. So this is premixed insulin human. So this is with the short-acting insulin. So as you can see, it's a little bit more of a flatter line. And then there's the insulin analog, which is with the rapid insulin. So both of them use NPH. Both of them use the intermediate as the basal, but they either have the short-acting or the rapid-acting. Most of the time, these insulins are taken twice a day, rather than the other ones that we saw. You could technically take it with every meal and once at night or in the morning for the basal. But the premix, most of the time, it's twice. So first thing with the breakfast, in the morning with breakfast, and before dinner. And that should cover the lunch and a little bit of like the night snack if there was any snacks at that time. So these are the insulin types and their actions. We'll discuss the technique of how to do injections and what are some tips that we could think about when we are teaching patients how to perform insulin injections. So I'll be demonstrating it. Of course, you have the slides here. It says all the steps, but I feel like sometimes it's easier to just interact with the camera. So this is what I have an insulin pen over here. Usually there's always going to be an expiry date on it. That expiry date is when it's not open and when it is kept in the fridge. Anytime you open the insulin, start to use it, the expiration date changes, and I'll be going through that in a little bit. When you open, the lid, there's the insulin over here. This is where you would put the needle. There's a little plunger, this orange thing over here. As people use the insulin, they'll see the plunger going up and up and up until it's at the very top. That could indicate that there's not enough insulin left, so they would need to make sure that they have enough for this dose, or if they don't, then they would need to open a new pen. There's always a dial right over here, and this is what we call units. So when we say, oh, this patient is taking 10 units of insulin, Tresiba, or this is what we're really referring to. Most pens come with 300 units, except maybe a few that would have more. So Tresiba has actually two. It has a like 300 unit pen, which is like this, and then it has a 600 unit pen. This is for people who need more insulin to take during the day or during the week. And over here, there's like that little button that you push the medications out after you have attached the needle, of course. So I'll show you here. This is the needle that we use. I have BD 4 millimeter. Most people are recommended to be using a 4 millimeter one. And with that, you don't need to pinch. You just inject it at a 90-degree angle, and I'll show you that. So first, of course, we have to tell them to remove the wrap, the green the wrap, and you take this needle, you put it right at the very top of the pen, and you screw it on. So it's usually righty-tighty, lefty-loosey. You remove the white cap, and then there's usually another cap that needs to be taken away. This is a green one. Some companies will have like a little blue one. It's very important to tell patients to take both of them out. I've had patients who forget to take the second cap and they inject it, but then obviously there's no insulin going in. After you've done that, you would dial 2 units. Usually 2 units is enough, and you just want to like push out a little. This is what we call priming the pen. It's squirted a little. So that priming is important to be done every time, not only with new insulin pens, because you want to make sure that the needle is put on properly, there's no bubble, and you never know, sometimes there's faulty needles that just won't work. So you want to do that and encourage your patients to do that with every time. Now that I know and I see that the needle is working, the insulin came out, then we would tell them to dial to the units that they need. So let's say they're taking 10 units, so they dial to 10. I don't know if you can see it. Yeah, so it's 10 units, and then they would just, let's say that this is my abdomen, so I would go and take it at an angle, right? Sorry, at a 90-degree angle like that, and then just push it all the way. Now, something that I usually like to tell my patients is to always hold the pen where they can see the dial over here, so that they can see where the needle, the units are coming down. And a lot of the times people are scared and they end up pushing too much, and this would happen on their skin. That indentation is not really supposed to happen. It's a very light touch. The needle is supposed to be very sharp because they're supposed to change it whenever. So the needle, when it's very sharp, it should go in very easily in the skin, and they don't really need to apply a lot of pressure. So the easiest way to hold it to prevent that pressure from happening is to hold it like a hitchhiker, like that, and then do that. Keep looking at the dial, push it. Once it's back down to 0, they count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. They count to 10, and then they remove it. And then the injection is performed correctly. You take the white cap. Now to remove it, the white cap, you don't need the smaller one. Just put it right at the top over here like that. Unscrew it, lefty-loosey again. And that's it. That's how they do the injection with the insulin. Pretty simple. Very important to remind patients of some of the tricks over there, so that they make sure it's always done properly. Now, these needles, they're in Ontario, probably in other places too in the world. They have a sharps container that you can get maybe from the pharmacy. I'm not sure, but in Ontario, we have that sharps container that we can get from the pharmacies. We dispose all of the medications like insulin pens, needles, the strips, the finger pricking, the lancing devices, the lancing sets. We can dispose them there because they're of course sharp and they're biohazard waste. So we need to throw them in a plastic container, bring it to the pharmacy, and they will dispose of it. I'm sorry, I don't have one now. I just have a little plastic container that I just keep it for demo purposes, but you guys should have that there. All right. Now, in terms of injection sites, it's always important to remind patients that the best absorption site is always the abdomen. You want to stay away from any scars, scar tissue, at the belly button or the navel, about 2 fingers away from the navel. And they have like pretty much from the little bit down from the rib cage all the way to the hip bone. That area, as demonstrated here as well, that's where they can do the injections, and it's the best absorption site. If they get tired from the area and they want to change a little bit, they could do the upper outer thigh. That's also fine, or the back of the arm. In terms of preference, it's always abdomen first, thigh second, and then the back of the arm third. And the reason why it's a little bit difficult on the arm, it's sometimes hard to do your own injection there, and the chances of you hitting a muscle is quite high. And if you hit a muscle, then the absorption is going to be a lot faster. So the results of the insulin and on the glycemia is going to be different, and unpredictable. So that's why. All right. Now, in terms of the injection, when they choose a site, you always want to remind them to change it up. So left, up, right, down. They can follow something like this, where they do, a spiral of like each quadrant of the abdomen, or they could follow something that's like a calendar. sorry, you can't see it. I have other stuff there, but it's like a calendar, about 1 finger or 2 fingers away from each injection. The reason for that is we don't want the skin to be developing hypertrophy or lipohypertrophies. These are little skin reactions, you can say. It's a little fatty tissue that starts to develop underneath the skin. It's because of the pressure, because of the tension that happens in the same area every day, whether it's not changing the needle or whether it's using the same site for the injections. It's a very good idea to help to remind them to change up the site and the needle. And the reason why this is, becomes a problem is it doesn't help the insulin get absorbed quickly. So many times you will need to increase the insulin dose, but then when they go to a fresh site that does not have that hypertrophy, then they're going to have a low sugar because the insulin has already been increased in the dose, but then there's nothing that prevents it from being absorbed. So the chances of hypos are high. In a case where maybe you're seeing a new patient and they've already have that lipohypertrophy, and you notice it on their abdomen or their site of injection, you probably won't want to, of course, remind them to change it and go to another site. But most of the time you would want to reduce the amount of insulin just proactively to prevent the low from being an issue. So it's something to keep in mind. In terms of injection timing, I think I briefly discussed it earlier. So the basal insulin, background insulin like Tresiba, Levemir, Lantus, Toujeo, these are all taken at the same time of the day, every day. Most of the time it's taken in the evening at bedtime, but you can also take it. You can also suggest that the patient takes it in the morning if it's a better time for them. Like let's say they have a irregular sleep schedule and you find out that they're missing their injections at night because of that, then you can tell them to just take it in the morning, and that should help solve the issue. The bolus insulin, the rapid specifically, typically is 10 to 15 minutes before they eat the meal. There is one exception to that, which is FIASP. FIASP is a very rapid insulin, and it starts to work roughly within 4 minutes. So that one, they can take it right at the start of the meal or even right after the end of the meal. That would be still okay, and it will still work well for them. There's a little tidbit over there, of course. Bolus insulin is always carb dependent. So if they're eating more carbs or less carbs, the dose of the insulin is going to be different. And this is something that we need to be careful with and remind patients to be mindful of when they are doing their injections. In terms of storage of insulin, we want it always to be, if it's unopened, it's in the fridge between 2 to 8 degrees Celsius. If it's opened, you can keep it at room temperature, but probably I would say room temperature would be like 25 degrees or so, definitely no more than 30 degrees. And it has to be avoiding any like extreme heat, sunlight. I'm sorry, I'm not sure what's happening. Someone's just like scribbling on the slides. So the so the insulin that's opened, it has to be done. It has to be kept in room temperature, no sun exposure, no heat. Freezing also it is not going to be good for that. Most of the time, the insulin is clear. Unless it's NPH or mixed insulin, then it will be cloudy, and it would need to be cloudy. So any other insulin that the patient has taken, if it has a different texture, if it's not clear, maybe it's best to discard it and then use a new one, because that could mean that it was already spoiled. When it is open and at room temperature, it usually stays for 28 days, 30 days. Most of the time, it will be written down on the actual pen or the box of the pen, so you can always make sure with that. But there are some exceptions to that. Tresiba stays outside in room temperature for 8 weeks, And Levemir and Toujeo, they usually stay outside for about 42 days. I would say it's helpful to mark down the date of when the patient opened the insulin, just in case they don't use enough that would be done in the 30 days. They would need to discard it, even if there was some left, discard it and then start a new insulin pen. So in terms of side effects for insulin, there's usually the one side effect, which is hypoglycemia, and I've kind of alluded to that earlier. It's when the sugars go down under 4, maybe too much insulin, or maybe long gaps between the meals, or maybe the meal did not have enough carbohydrates. So those are all some factors that could influence and cause lows. So the treatment is usually check the blood sugar, advise them to take 15 grams of rapid sugar or fast-acting sugar. Could be 3 to 4 glucose tablets, so it's Dex4 tablets, or 2/3 cup of juice. Some people do a tablespoon of honey or a tablespoon of just regular sugar. They could put in a cup of water and drink it. Wait 15 minutes and then check the sugar again. If within 15 minutes the sugars are now back up above 4, then they can go ahead and have a snack or maybe a meal, whichever comes first, and make sure that that meal and snack is balanced, meaning it has protein, it has carbs, it has maybe some vegetables, something to sustain them so that they don't go down again, because that could be a risk for that. In terms of the symptoms that they might feel with the lows, could be sweaty, shaky, dizzy, weak. Some people get irritable. Really, people can experience a variety of different symptoms. So anytime they feel something different, usually a good idea to check their blood sugar and ensure that it's not a low. All right. Now, we'll talk about smart glucose monitoring. Is there a way that I could clear this yellow scribble? I'm not sure how to do that. It's just gonna be there.
Even I don't know where is this coming from. I
don't
just
know.
manage somehow.
All right. So for smart glucose monitoring, this is a reminder that most of the time, the fasting sugars, or any time before you eat a meal, the sugar should be between 4 and 7 millimoles per liter. This is again for people with diabetes. I'm not referring to anybody without that right now. After the meals, most of the time we recommend 5 to 10 millimoles per liter, which seems to be acceptable. But if the patient is not meeting their A1C target with those ranges, like they are still aiming for 5 to 10, but the A1C is still over 7, then that means they might need to be tightening the control a little bit more, and they would need to aim for 5 to 8 after 2 hours of eating. How often should they be checking the sugars? There's a rule of thumb there, which is check at least as often as the insulin is taken. So if they're taking a basal insulin, let's say like Tresiba, and they're only taking it once a day at nighttime, then they would need to check once a day as a minimum, which is usually first thing in the morning when they wake up, because that's where the basal insulin usually works, as I discussed earlier. It's during times of fasting when there's no food involved or overnight. They could also check it at bedtime to give them a little bit more insight as to what's going on. Let's say the sugars are high in the morning and they don't know if it was because Tresiba is not enough or because they had a very big dinner the night before, and that's why the sugars were still high in the morning. So usually you would want to do that kind of checking as well. If they're on a basal bolus regimen, so they're taking a mealtime insulin with every meal, like with breakfast, lunch, and dinner, and then they're taking a basal insulin at nighttime, then the recommendation is, of course, would be minimum 4 times a day, right? So before every meal and at bedtime is the general recommendation. So first thing in the morning when they wake up, before breakfast, then before lunch, before dinner, and then at bedtime. And that way we can be we are able to adjust their insulin accordingly, find out the patterns, and help them improve their glycemic control. There are some times where you would want to ask your patients to check more often, like for example, when they're sick, if they're exercising, maybe at risk of low, you would want to do that. If they're pregnant, and of course, when there's a period of insulin or medication adjustment, the doctor is making changes and you would want to make sure that these changes are working well, you would ask them to check a little bit more often. When checking the blood sugars, make sure that the meter is accurate. Otherwise, all the checking is going to be useless. So the age of the meter, adequate blood sample, and they're doing the finger pricking correctly. Make sure that they're cleaning their hands before. There are times where there's like residue of food or carbs or sugar in the finger, and that gets picked up in the strip and it will read a high sugar even though it wasn't. So something to keep in mind. And the temperature sensitivity of the strips. So the strips always have to be in their little can, sealed, put away in a room temperature, avoiding any exposure to extreme heat or cold. Of course, now with the technology, we have Dexcom, continuous glucose monitor, or flash glucose monitor with Libre. Both are really good, and they help people understand more about their diabetes, the way that their body reacts to different foods and exercise and medications. So with technology like that, it would be a lot easier for them to be monitoring their blood sugar other than like checking with the finger prick every meal or so. So if your patient is having a lot of trouble with the finger pricks, you can suggest them these options, help them get introduced to them, and hopefully that would help you and the patient improve the overall control. Now, when we're taking a look at the blood sugars, when we see the readings, we have to always have, some sort of analysis of what's going on. So if the sugars are high, if they are above the target, we have to ask, okay, well, what were the factors that could be affecting it? Maybe there was too much carbohydrates. Maybe they were stressed out. There's an illness or mental stress, emotional stress. Maybe their insulin is not sufficient, or maybe it's expired, it's spoiled. Who knows, right? Maybe they're missing some of their other medications. So these are questions that we would need to ask when we see high sugars. With the low sugars, there are factors that could be affecting that, like physical activity more than they're used to, alcohol, too much insulin, delayed meals, or skipping meals altogether. That could also be leading to low sugars. Alcohol brings some questions often, and the reason why alcohol can lead to low sugars is because the liver is the organ that takes away the alcohol from the body, but it also produces sugar when the sugars are starting to go too low in the blood. But unfortunately, it can't do both, can't simultaneously do both of those tasks. So if there's a lot of alcohol in the body, usually the liver will prioritize that, and it will kind of put the sugar production on the back burner, and people may experience low sugars up to 24 hours after drinking. So it has a delayed response. It might have a high sugar, like people might have a high sugar after drinking right away, but the low can happen after. So the general recommendation there is, of course, they can have alcohol, that's fine, but make sure that it is with a meal and a snack. Don't have it on empty stomach, which is pretty standard. Drink lots of water, and make sure that they check the blood sugar before they go to sleep. And if it is in the lower ranges, 5, in the 5 range, 5.5 or less, then you would want to recommend that they have a small snack before sleeping at night. I, of course, always recommend that they check with their doctor and the pharmacist to see if there's any contraindication for alcohol with some of their other medications that they are taking. So now that we know why, you know, the sugars were high or low, and we've asked them the questions of why they might be. If it was a one-time thing or a two-time thing where the sugars were high and we already explained why they happened, then we can maybe just work on the behavior to try and fix that. But if we start to see that the pattern is happening without any other factors, or we've eliminated the other factors, but the sugars are still high 3 times at the same time of the day, but different days or more, then that could mean that we just need to make changes to the insulin at that point. The hypoglycemia, or a low sugar, if the sugars are below target 2 times or more at the same time of the day, but different days, that could also indicate a pattern for a low sugar. So the reason why we choose, you know, 2, it has to be a low sugar two times rather than 3 or more, is because lows are more dangerous and you want to act on it very quickly, and you want to help your patients prevent them as much as possible. So when we are finding that pattern and we say, okay, well, now I found a pattern that I need to fix, what do I fix first? There's usually an order for it. There's a priority order. So first, we always have to fix the lows first, wherever they happen. If they happen in the morning, at nighttime, before lunch, always fix the lows first. Second in order would be fixing the high sugars before breakfast, or the fasting levels. Because if we get the fasting in target and all the other readings or all the other insulin and meals are okay, then ideally all the other levels are also going to be fine and in target. So always fix the fasting next. Third, you fix the high sugars before other meals. So we fix the high sugar that's happening before lunch, before dinner. And then the last priority is to fix the high sugars after the meals, those 2 hours after. And the reason why we do this is, again, it's all because of safety and because we want people to be proactive, and we don't want to react to high sugars. We always want to be fixing or getting on top of the blood sugars in advance of you know, when things start to happen. So now that we know the priority of, like, the order of which insulin or what we need to fix first, now we need to see, well, which insulin do I change to bring about that change that I want to see? So we always take a look at what the current blood sugar is, and then remember that this sugar right now is reflective of whatever happened previously. So we're always taking a look at the last thing that happened. So if I check my sugar before breakfast or at fasting and it's high, it's really going to be whatever happened last night that could have caused this. So either the basal insulin that I took was not enough, which most of the time that's the case, or if the dinner was really big and the insulin for dinner is not enough, that I end up with a bedtime reading of more than 10 already, then that could be something that I would need to look into and adjust and see if it would bring about the change that or the improvement that I would want to see. So the before breakfast readings are a little bit, you know, it can happen. You can be fixing it with 2 ways. You just have to make sure that you are getting the readings at bedtime as well, so that you can have an informed decision of what to change first. If you want to see the blood sugars before lunchtime, then we're always taking a look at what happened before lunch. So the breakfast dose of insulin that they took, the rapid insulin, then maybe that wasn't enough, and that's why the sugars before lunch are high, or maybe it was too much insulin because the blood sugars before lunch are low. So always look at the last thing. Before dinner readings, we take a look at the lunch insulin, and the bedtime readings, you know, the HS or nighttime, that usually is reflective of whatever happened with the dinner dose. So that's usually the way that you would distinguish or recognize, okay, well, which insulin do I need to change now based on these patterns? Now I know the pattern, I know which insulin to change. How much do I adjust it by? What do I do? We always make a change or an increase, decrease by typically 10%. That's what we recommend for our patients to do. For you as a professional, and if you are helping your patients do the adjustments, it depends on your medical directives. Most of the time it's 20%. You have up to 20% where you can make an adjustment. So it's really, it all depends on your practice and your organization. And remember that the blood sugars, of course, are 4 to 7 before the meal, 5 to 10, or 5 to 8, 2 hours after the meal. So I have a little practice over here. I figured if we have some time, we can do it together. Why not? So why don't we do that? So I have a patient logbook over here in front of me, and this person is taking basal insulin, let's say Lantus. They're taking 10 units, and they're also taking NovoRapid before each meal at 10 units as well. Keep it simple. What do you think? What do you think? What are the patterns here? What do you think we should be working on first? I don't know if you guys want to like share it on chat. We do have some time, so it's up to you guys.
Y'all can share on chat, like if your thoughts and your answers.
So we have before breakfast readings, before lunch readings, before dinner, and then at bedtime. So which numbers are higher than our targets? Okay, I have an answer here, working on FBGs first. Yes. Need to fix basal insulin. Great. Yeah, absolutely. So definitely I would say, like, before all meals, we are above target here, right? Because they're all over 7. Which insulin or which one would we be prioritizing first would be absolutely correct, the fasting, because there's no lows. So the next in order would be the fasting sugars. And which insulin would fix it is usually the basal. So yes, I would have to agree with that. And also another indicator here is that bedtime readings are in target. I mean, they're not really high. So we don't think that the dinner dose is not enough. So that's why basal is the correct one, the correct answer. Great, awesome. All right, so there's another one over here. Now that we made that change, this is what we end up seeing. Now, what do you think needs to happen? Now our before breakfast seems to be in target, right? It's under 7. Before lunch seems to be under 7 as well. What needs to be changed now? Someone's saying dinner rapid dose. Okay, any other answers, other ideas? Remember, it's before, so these are before readings, not after. All right, lunch, perfect. Yes, yeah, so before dinner readings are above target, they're above 7. So we would ask, okay, what was the last thing that happened? It was probably the lunch dose, maybe was not enough. So we would increase the lunch dose by about 10%. So maybe we would do like 11 with lunch, and then hopefully the dinner dose the dinner readings are going to be better after. Great, thank you. All right, now what do you think we need to do? We did that, and this is what we see. Do we need to make any changes at this point? We have one low before breakfast, but the rest of the readings are all in target. Yeah, so no trend, and their blood sugars are fine. It's not a trend. Doesn't mean that we don't ask them about what happened there. I mean, obviously, you can always ask the patient, say, well, what did you notice the night before? Maybe they ate a smaller dinner, or maybe they were very active, or something happened that could have caused the low to happen. So we would just counsel them on that behavior that could have led to the low. But if you see it happening consistently, like if it happens again, if they have another low at breakfast the following day, then you may want to take it a little bit more and like maybe ask them about the insulin doses and probably reduce that to be on the safer side. And you would probably reduce the basal insulin at that point. Great. Well, thank you so much for participating and give me your answers with that. We have come to the end of the session, so I'll open it up now for questions. If there were any, you can let me know, Noor, and I'll be happy to assist with them.
Yeah, for sure. Thank you so much for sharing all this valuable information. As Tara said, we will now have our brief Q&A session. So if you have any questions, please leave them in the chat box and Tara and I will read them out together and we'll give you the best answer we possibly can. So we'll take a couple minutes, just drop in any questions if you'd have any. So we have one question. This is, I have heard you have to roll the pen a few times before use. Why is that?
Very good question. So this applies for cloudy pens. So intermediate pens usually, or pre-mixed pens, you would need to always roll them because you want to make sure that they are cloudy. When they come, like if they're settled, they're clear, and you can't do that because it's not mixed probably. So you roll them 10 times, and then you maybe like go like this, up and down 10 times. If it's white, then that means you can start to use it. Of course, my pleasure. I'm glad that you guys find it informative. No problem. Was there any other questions while I was doing the presentation, or?
Okay, one more question. This says, if a person BGL spikes after using rapid acting insulin and their dosage will be 50 units a day.
Okay. Is there a? So I'm not sure what the question is, but if you're asking about the amount of insulin, if it's too much, it doesn't matter. So in terms of the insulin dosing, you need to give the body what it needs. So there's no limit. There's no like maximum dose per se. It all depends on what the body requires, how much insulin the body is making on its own, and then how much you're going to be given from the medication. So that's why we adjust it slowly. We increase gradually until we reach a level where a person is at target. So even if the insulin dose is going to be more than 50, if that's not bringing them, if that's not bringing them too low and it's keeping them in range, then that's fine.
Thank you. One more question. This one says, if a patient is having a high protein, high fat meal and their sugar gets high, how would you guide them about insulin adjustment?
Great question. So yes, if it's a high fat, high protein meal, we sometimes see like a delayed rise in the blood sugars. So blood sugars are not going to rise right away like they would with carbohydrates only. They would rise maybe like after 2 or 4 hours. So you would maybe depending on the patient, sometimes we would tell them to do 50-50. So 50% of the dose at the beginning of the meal to cover the carbohydrates in that meal. And then the 50% could be like halfway through the meal or at the end of the meal, so that they could get a little bit of that rise to match with the protein and fat digestion. If they are doing carb counting and they're dosing their insulin properly for that, they would need to account for the amount of protein exchanges and fat exchanges in that dose and take it for that as well. Yeah, good question.
All right, we have 2 more questions and then we'll wrap it up. Any remaining questions that anyone has, feel free to send them to the email. We will pass them on to Tara and she'll definitely get back to you as soon as possible. So this other question says, 3 packets of sugar during hypoglycemia would mean how many approximately grams of sugar?
So most of the time, the 1 sachet has about 5 grams. So they would need to take 3 because it's 15 grams that they need. It's a tablespoon.
Okay, and last question is, how do you calculate and decide on the insulin dosage and types?
So you mean if it's at the beginning, if they're starting on insulin, usually we have like Diabetes Canada, we have a guideline of the first line of therapy, is always lifestyle and management. If that doesn't work, you move down to metformin and lifestyle management, and then we start to introduce some other medications. Oftentimes, if a lot of the other medications are just not working, then the decision would be made to be going on insulin. I would say in my practice, a lot of the times it's the doctor's decision, and then, or if we see during our counseling that nothing is really bringing the sugars down and the lifestyle is becoming more of an issue, then insulin could be started at that point. In terms of the dosing, most of the time for rapid insulin, I would say 3 to 4 units, and the basal insulin typically is started at 10 units, unless the person has like higher weight or lower weight where we would need to make certain adjustments to that rule. So usually with lower weight individuals or elderly patients, we would maybe start the basal insulin at like a 6 rather than a 10. And the rapid would be started like maybe a 2 units or 3 units rather than anything else higher. And then we adjust it slowly after. And it's usually a decision that, the doctor would be making rather than the educator.
Great, thank you so much.
No problem.
I think we will wrap it up now. That was a wonderful session, Tara. Again, thank you so much for all of the valuable information you've shared.
Of course.
I'm sure that we are all much more familiar with insulin now. Feel free to check out our previous webinar as well with LMC Healthcare. There was also tons of valuable information in there. Other than that, to learn more, you can also take a look at the many courses that IE Dietitians Network of Canada has to offer, including our diabetes educator course. So you can get lots more information and lots more expertise in this field as well. Feel free to reach out to us if you have any other questions. We will be sending a follow-up email just so you know what to send it to and all of that. But other than that, once again, thank you so much and have a great day, everyone.
Thank you. Stay
Thank you,
safe,
Tara,
everyone.
and thank you, everyone.
Bye.